All right, hello everyone, and welcome to the Race Academy digital program to the 5 keys of predictable results. We're just waiting for the last of you to log on board now. We've got enormous amounts of numbers for this topic today, so I'm pleased to see that we've got people from all over the place. I'm just having a look where all you guys are from. Obviously, we've got the majority from Australia, but we've got an enormous amount of people here from New Zealand. We've got some people from Canada. Hello, and Saudi Arabia, fantastic. Pakistan, welcome to everyone from Pakistan. Hungary, Malaysia, Japan, and Singapore. So we've got quite an international array of people here today, so it's exciting to see. I think we're probably right on the money. So before I jump in and pass you over to our guest lecturer today, I just wanted to introduce Dr. Jeffrey Hall. For those of you that joined us last time, you'll know of Jeff. I'm pretty sure he's probably well known and renowned across the globe. He's been a dentist since 1983, an orthodontist from 1990. And for those of you that don't know, Jeff was the first person in the world to do an Invisalign case outside of the US. So he's definitely well attuned. He's done 10,000 cases, I think, or plus, and counting. He's been a lecturer at a bunch of universities, and he's the founder of the OrthoEd Institute. So he's well positioned today to take us through and lead us in today's technology or lecture in regards to 5 keys of predictable aligner results. So to no further ado, I'll pass you over to Dr. Jeffrey Hall.
Matt, thank you for your very kind introduction. And thank you, Matt and Race Dental, for inviting me to present another lecture on a really favourite topic of mine, which is the 5 keys to predictable aligner results. What you really need to know to make aligner therapy work well, and basically what many people have been afraid to tell you about. So, most of you who know who I am, so I'm not even going to go through all of this now. Matt gave a very kind introduction. So I've been an orthodontist now for over 30 years, and personally I've treated over 10,000 patients myself, but I've been involved in aligner therapy now since, I think it was early 2000, so over 20 years ago now, when I did my first Invisalign case. And I like to do a lot of myth busting, and I'm going to do a lot of myth busting even with aligners, and see if we can hone in on the most important facts that you need to know to make your aligner treatment very successful and very predictable. But before we start, a lot of people have asked me, what's the difference between God and an orthodontist? And I was searching through the literature, and I realised the difference is God does not believe he's an orthodontist. And I say that quite truthfully because most of you guys out there are general practitioners, and you hear it all the time where you guys can't do orthodontics, etc., etc. It's not true. Orthodontics is actually very straightforward if you understand principles. So, as in all my lectures, I like to have a key slide, and so this is the most important facts that you need to make sure that you fully understand in the presentation. So, braces or aligners, and this is the question that gets asked all the time. What's the difference between braces and aligners? And there aren't that many differences, really. We know braces are fixed on the teeth, and what we have is a sequence of wires that we use when we progress from a light to a heavy to a stiffer wire. We can use round or rectangular, and basically they apply a pulling force. So the tooth is pulled to the shape of the wire. So the tooth is actually pulled to the shape of the wire. Aligners, as we know, are removable, and therefore being removable, compliance is really important. We also know that there's a sequence of different aligners to progressively align the teeth. So basically what we do is we place the aligner over the teeth, and the material distorts. So there's this stored energy within the aligner, and that energy gets released because the aligner wants to return to its original shape and bring the teeth along with it to that predetermined position that the aligner's been made of. Yeah, so very, very simple in concept. But the difference is that aligners have a pushing force. So when we look at this, so aligners have a pushing force and braces have a pulling force. Now, this may sound very, very logical, but it's really important to understand the difference between the two, because that will determine so much of the way we manage our cases. So once we start to get the concept, aligners push and braces pull. So as we know, aligners will be placed over the teeth, and that material has what we have, the stored energy. And that energy is released. The aligner wants to return to its original shape, and it brings the teeth along with it to that predetermined position. But what's the most important fact is the better the aligner holds onto the tooth, the more reliable is the tooth movement. So that's a key slide. The better the aligner holds onto the tooth, the more reliable is the tooth movement. So, are there any biomechanical differences between aligners and braces? And I'm going to say, yes, there are. Something that people don't fully understand. So, here we are, where we basically, if we put braces on this patient, for some reason, and we won't go into the ins and outs, but whenever you put braces on a patient, what tends to happen is the bite anteriorly wants to open. Could be because there's extrusion of posterior teeth. Whatever it be, whenever you talk about braces or fixed appliances, there's a tendency for the bite to want to open anteriorly. So before, and we find the bite starts to open anteriorly. This very often happens with braces. And like I said before, one of our reasons is we probably get some extrusion of these posterior teeth with braces. It can be minimal, but 0.5 millimeter of posterior extrusion can open the bite anteriorly by 1.5 millimeters, could be even 2 millimeters, depending on their vertical pattern. But there will always be some bite opening with traditional braces. The converse is true with aligner therapy. And aligner therapy, the patient wears significantly. And by that I mean we've got 2 pieces of plastic now between the posterior teeth. So now we have an intrusive effect on those molars. And what we've seen in the past in our treatment is if patients wear the aligners very well indeed, and let's say the patients have a grinding habit or what we call a brachyfacial and strong posterior musculature, they will actually intrude these posterior teeth even more. So what we see is a situation of a posterior open bite. And this was actually one of my staff members that after 25 aligners, look at the posterior open bite that's occurred. She was a fantastic wearer of the aligners, and it caused posterior intrusion and a deepening of the bite anteriorly. And this is a really important concept, because had we put braces on for this patient, we could have ended up with an anterior open bite. But with aligners, we tend to deepen the bite. And that's probably the big difference between aligners and braces. So braces are great for bite opening. Aligners are great to close the bite. So, and on the converse is true, if you've got a patient with a very deep overbite, aligners can be very difficult in opening the bite. You've got to be very careful and know what you're doing, because the tendency is to intrude the posterior teeth and make the bite deeper anteriorly. So we can show you case after case where this case was treated with aligners and they had 3 years of aligners. And as a nice result anteriorly, the bite sort of closed down, but because of the long-term wear, we see the posterior open bite. And we see that very routinely in patients who have aligners in place for longer than 12 months and are wearing them. So we have 5 commandments for predictable aligner outcomes. First commandment, thou shalt apply the correct attachments based on biomechanics. The second commandment, thou shalt create space to allow for efficient and predictable tooth movement. The third one, thou shalt plan aligner cases in basically the same way as planning a case involving braces. Our fourth commandment for predictable aligner outcomes. With my aligner, thou shalt overtreat. We'll overtreat intrusion, overtreat torque, overtreat tipping, overtreat expansion. And the fifth commandment, which is absolutely essential, they're all essential, but the fifth commandment, which is really up to you from a clinical point of view, thou will make sure the aligner is fitting all the time and have both the dentist and patient checking that contact points are free and there is no binding at any time. So let's go through in detail these 5 commandments of aligner therapy. So the first commandment is thou shalt apply the correct attachments based on biomechanics. Now this is not difficult, but you've got to understand what we're talking about here. So let's talk about aligner attachments. And it doesn't matter what system you're using. The principles stay the same. Whether you want to use Invisalign, you want to use Smile Style, you want to use any aligner system, it doesn't matter. In fact, I would argue that some of the more conventional attachments that we're going to show you are actually better than the storytelling behind some of these attachments that you see on the screen here. So, first point is remember aligners push. And what attachments do, they provide additional surface on the tooth to allow pushing when and if needed. So the question then is big, which movements do we need these attachments with? So when we consider attachments, we are making sure that we maximize the surface area that we're pushing against. And I use the analogy, you can push something with your fingertip or you can push it with your entire hand. And obviously it's much better if we push it with the entire hand. So we want to maximize that surface area. And different types of movements will require different shapes and sizes. And we've got some attachments which we call active attachments, and some are what we call more retentive in nature. So, principle, the forces should be applied perpendicular to the attachment and the tooth surface. So, we have all these different types of attachments that we can use. We used to have this ellipsoid attachment, and it's still seen today. It is a useless attachment. So we never use that attachment at all. It doesn't give you enough extra surface area. It doesn't give us a surface to push against. So therefore, it doesn't do anything that we need. So we have what we call rectangular attachments. They could be vertical rectangular. They could be horizontal. They could be beveled or non-beveled. But they're basically rectangular in nature. And so here they are. There's a rectangular one. There's a beveled one. You could theoretically use a beveled half ovoid, triangular. They're all different types. But we're going to stick to mainly the rectangular and mainly the beveled ones. They're the 2 types of attachments that we use probably 99% of the time. So there are all these different types of attachments that you see. Vertical. This is the ellipsoid attachment. I don't believe there is any indication for an ellipsoid attachment today. It does nothing. So when you look at these attachments, you can see where the surface is. You want to be using the surface to push against because aligners work as a pushing force. So keep thinking about pushing. How are you going to design attachments to allow these attachments to push better? So you've got a rectangular attachment and you've got a horizontal attachment. And then here you've got a beveled attachment. And the beveled attachment will allow a pushing force to occur on the beveled surface. So I've got a much better surface to push against here. And in the old days, we used to just use these horizontal attachments, but I'm going to show you they're very non-forgiving, the horizontal attachments. So, for example, when we extrude a tooth, there's nothing for the aligner to grab onto. So how does that tooth extrude? We need something for that aligner to grab onto. One of the great mistakes that we see all the time. And extrusion is not just reliant on attachment alone, but also proper management. So we have to design this force system so it's got a pushing rather than the pulling effect. And as I'm going to show you later, we've got to make sure there are no collisions. And sometimes with extrusion, we've got to reduce what we call the velocity of movement. There's no point trying to extrude a tooth very quickly and we lose control. We lose control of the aligner within that attachment. So sometimes you've got to slow down the movement of extrusion. So for example, as we extrude a tooth, if the tooth collides, it's a constraint of the system. It stops moving. The biggest mistake we make is to go ahead and extrude teeth or to move any tooth, as you're going to see, and there's a collision occurring. And you're going to say to me, but we know that because the software tells us that there's a collision there, and the software tells us that we need to do IPR. And I'm going to tell you that's a load of garbage. There is no software out there which can tell you that, and I'll explain to you why later on. They all tell you the story that you do IPR here and here, but it's not true. And this is where the clinical part comes into play and why we used to have all these mistakes made. But I'm going to show you some really simple ways to keep you in control of this case clinically. Very simple. And if the teeth do not extrude properly, if the teeth don't extrude properly, you end up with a lack of fitting, or what we call lack of tracking here. And there's a couple of reasons why this tooth has not extruded properly. One reason is going to be there's probably a constraint in the contact point. And the second reason is, as I'm going to show you, this attachment is exactly the wrong attachment to use. The last thing you want is a vertical attachment here, because what's it pushing on? It's only pushing on this little surface here. You want an attachment which is a horizontal attachment, and you want it to be beveled to have a much better surface to push against. So start to think about the pushing force that's required and the constraint in the system. So this is what I was talking to you about before, about when you have a horizontal attachment, and this is what we call bevel to the incisor. And if you've got a horizontal attachment, and let's say it stops tracking, it's unforgiving, because as soon as it stops tracking by a little bit, it becomes unforgiving and it's no longer active at all. It's no longer causing that extrusion to occur. So what we now find is we now go ahead and do these extrusive attachments. They are beveled towards the gingival, because this way, let's say you have a little bit of a lack of tracking, you've still got total contact on the attachment, and you still got that force which is perpendicular to the tooth surface. So we find that these horizontal attachments, to get that extrusive force, we are far better to have those beveled towards the gingival. They're far more forgiving with regards to extrusion. So the best way to extrude the tooth is keeping that force perpendicular. So sometimes you need to actually move the tooth to the labial first, and then the force is going to be perpendicular, so it's going to not only extrude it but retract it at the same time. So sometimes it's to do with the staging of treatment that you need to look at, where I might have to move the tooth to the labial first to get a better contact of that tooth and get better contact of that pushing force against the attachment and against the tooth. And one of the key things with aligners, the way they work best, is to obtain full surface of coverage. The more we can cover the tooth, the greater our force system is with an aligner. So sometimes by pushing the tooth out a little bit first, what we would call in orthodontics round tripping, can give a better end result with aligner therapy. And that's to do with the staging of the treatment. So if we want to go ahead and intrude teeth, we also realise that for every force that we put on teeth, there has to be an equal and opposite force somewhere. So we would go ahead and intrude these teeth. So we're going to force anteriorly, but there must be an extrusive force posteriorly. Now, if we have no attachments on here, the aligners are just going to come off the teeth. And if the aligners come off, there's no intrusive force. So we then need to have some type of attachment to counteract these extrusive forces. And this is where you would just use a retentive type of attachment. A horizontal attachment, you don't need a bevel because you're not trying to extrude it. You're just using it as a retentive force system. So you need to have them posteriorly for a retentive force system. And if you don't, your intrusion will not work at all. So here we are now with our retentive force system, our retentive attachments. The aligners are going to click over that. And now, as these try to intrude, as these do intrude, the aligners can't come off the posterior teeth, making your intrusion much more effective. Because extrusion is a very difficult movement to do with aligners. Intrusion is a far easier movement to perform with aligners. So here, the most common tooth we find that doesn't extrude is the lateral incisor. Because there's not even an attachment on that tooth. And your question would have been, but Jeff, why should I put an attachment on? I wasn't even trying to extrude that tooth. But what about if we were trying to intrude the adjacent tooth? Where's our reciprocal side effect? Our reciprocal side effect would have been on the laterals. Hence, even if we're not actually planning any movement on the lateral incisors, we have to look at what's happening on adjacent teeth. Because if our plan was to intrude the upper centrals, we would have needed at least a retentive attachment on that upper lateral incisor. And if we don't, this is what happens. These teeth actually will end up not tracking at all. They will actually intrude. And we don't want that to occur. And the other problem is we've got to make sure that there's no constraint in the system. So, and this is what I find quite hysterical, is most aligner companies, most of them go ahead and say, well, we pre-program these attachments in. We have these special algorithms which are written. So as soon as you have 0.50 millimeters of extrusion in your plan, we're going to put an attachment on. But then I'm going to ask you the question, what happens if you have 0.49 millimeters of extrusion? You won't have an attachment because the algorithm is not written for that. This is why you have to have the knowledge and override certain things, okay? It could be 0.3 millimeters and you want to be pretty sure that you're going to put an attachment on, but you've got to understand what you're doing. So once again, to reiterate, these ellipsoid attachments are basically useless, and we're going to stick around into the rectangular horizontal, rectangular vertical area, and we're going to talk about beveled attachments. And so our key principles for attachments: visualize how the movement will occur and create a pushing surface. Consider the reciprocal side effects on adjacent teeth. So if intrusion is occurring on one tooth, reciprocal extrusion and attachment required on adjacent teeth. Horizontal attachments are used for vertical movements. So if I want to extrude a tooth, I'm going to use a horizontal attachment. If I want to tip a tooth, I'm going to use a vertical attachment. So remember that principle, it's so important. So you saw that patient before where I was extruding that upper right lateral and I had a vertical attachment on. That's just totally incorrect. And don't be afraid to replace or add in attachments. Okay, even if the technician prescribes it, you are the dentist. You are the one in charge of the case. You have got the knowledge. So do not be afraid to override it. Okay? When we deal with rotations, they are really difficult. Rotations, especially with curved teeth. So for those of you who've got experience with aligner therapy, you're going to tell me rotations with canines and premolars are very difficult. Okay? And what we're going to talk about here is we can change the attachments if you want. So we can actually, we don't have to always have a horizontal and vertical. We can change it into an angled attachment. This is what we call the Sash attachment. And the nice thing about that is it captures two different vectors of force. So we can rotate, tip, and extrude at the same time. So Upper lateral incisors routinely intrude. People who've done a lot of aligner cases say, hey, you've got a problem with upper lateral incisors, always. They'll intrude. It could be because you haven't got an attachment on. They're small teeth. They tend to be squeezed out. So to me, I always place an attachment on the lateral incisor every time now. And I'm either going to place a horizontal attachment or a sash attachment to try and keep the lateral incisor from intruding and being squeezed out. When we talk about rotation, what we want to do, remember, we want to push, we're going to push. And always make sure there are no interproximal collisions. So when I look at a rotation on a curved teeth, I basically say to myself, I'm going to place the attachments behind the center of resistance. So I don't place it here. I see it all the time. I want to place it distal to the center of resistance of the tooth. And I'm trying to push to rotate that tooth. So this is where the center of resistance is, and I'm going to be pushing to rotate that tooth. So my beveled surface should be here. It shouldn't be here, it should be here. So I'm pushing against the beveled surface. And I've got to make sure there's no constraint, because if there's a constraint, this is not going to rotate. So I'm going to need to do my IPR as well. And we'll talk about that in a few minutes. So here we are with always have your beveled surface. Remember, it's a pushing force. So consider the main movement of the tooth that you're doing and select the attachment accordingly. Visualize the direction of movement and create a pushing surface. And this is why I kept on saying right at the beginning, remember, you are pushing with aligners. Horizontal attachments are for vertical movements. Vertical attachments are for horizontal movements. And consider the reciprocal side effects on the adjacent teeth and use supportive or retentive attachments as needed. So, for example, if we're intruding anterior teeth, we need supportive retentive attachments on the posterior teeth. Don't tippy-toe around attachments. That's the best advice I can give you. Don't be scared to change them around. Teeth will only provide adequate anchorage if you put on the correct attachments. And this is the next part, which is so important. Thou should create space to allow for efficient and predictable tooth movement. So we need to get full exposure of the tooth. And this is what we do with brackets, etc. We do the full surface of the tooth exposed so the aligner can capture it. And we've got to get as much aligner material around the mesial and distal widths of that tooth to give you the best force system. So our aligner material should fully encompass the tooth. Buccal lingually, mesio-distally. Because if we can fully encompass the tooth, we've got what we call two equal and opposite forces. And the greater the distance between the forces, the greater is the couple. So the more we can encapsulate the tooth, the better rotation control and the better the tip control. So this is the key. In our aligner setups, we want to make sure that we stage it properly to be able to get sufficient aligner material around the tooth. And remember though, anterior teeth that are rotated require space to align them. So a tooth like this, we require space to align it because otherwise there's a constraint in the system. And when we do cross sections, we can see how we've got binding occurring. We've got binding occurring. And so whenever teeth are rotated, we require space to align. There cannot be any binding. So we either have to do IPR or we've got to find a way of gaining space in the setup before we derotate. In other words, we round trip. We bring the incisors forward, be able to encapsulate the entire tooth, and then we can do our rotation correction, etc., etc. So here, this looks fantastic. But we need to make sure there's no binding occurring. Now, what's going to happen here, what's going to happen here is your aligner system is going to say you need to do 0.1 millimeter of IPR. And everybody tells me this, but my aligner system tells me that. That is absolute garbage, because the way the algorithms are written, that's based on the fact that you've done 5 millimeters of expansion, whatever it be. What happens if you only get 2 millimeters of expansion? If you do that, you're not going to end up with the space that you need here anteriorly. So it's the numbers that you are told about the amount of IPR is based on 100% of the movements in your setup. That doesn't happen. We know that you're lucky to get 50% sometimes of the expected movements. Hence, this is why we need to overcorrect as well. So you need to have a clinical guide to say, do I need to do IPR? And in our practice, every time the patient comes, we go ahead and we floss the teeth. If there's any binding with the floss, any binding whatsoever, we do IPR. We don't even care what it says on the clinch check or the digital setup where the IPR is. We are going to look at it from a clinical point of view. The biggest mistake we make is we have binding occurring. And we've even got to the stage now where we give our patients a IPR strip and we tell them, if you feel that it's tight, go ahead and do a little IPR and make sure there's no binding occurring. Once you do that, your clinical results are going to improve by 90% straight away. Because you might see absolutely no IPR there on your digital setup, but trust me, there will be a lot of IPR needed. So IPR is an important part of aligner therapy because we need to create space to alleviate the crowding, and we have to reduce any binding, or what we call in ortho ed a constraint in the system. So IPR, if tight contact's present, we do it even if it wasn't prescribed. We check between the teeth at crowded areas with floss at each visit. Software, and the other part is the software, most software all allows for a minimal collision to occur. So you can't rely on the software to tell you that you need to do IPR. And most of the reason it's due to insufficient expression of movements like expansion, proclination of teeth. Because if those movements haven't occurred, and trust me, they don't occur, you will end up with a situation, where you need to do more for IPR than what is prescribed in your digital setup. And if you don't have the space, the teeth are going to intrude because it causes a constraint, and these teeth are going to move in and it's going to cause a squeeze effect. This is what we see so routinely on upper lateral incisors. It's been the bugbear of us for 15 years. Hence, every lateral incisor has an attachment now in my practice, and we make sure we've got sufficient room. So with IPR, you've got to make it simple. We've got to stage it properly. We've got to make it clinically efficient. So stage it for appointment specific when you're going to see the patient. I love it when I see IPR that says do 0.2 on aligner 1, 0.3 on aligner 2. Well, you're not going to keep the patient coming back all the time. So I get the technicians to group it to how much do I need to do for aligner 6? How much do I need to do for aligner 12? So it's grouped at the same time as I'm seeing the patient. And sometimes we ask for round tripping, bring the incisors forward to gain the space, and then we can accomplish the movements required and we can retract with IPR. For example, we round trip by bringing the teeth forwards. We can now encapsulate the entire surface, and we've got better access for the IPR as well. So when they're forwards like this, we can do the IPR far more efficiently than we can when they're very crooked. So sometimes it's worthwhile doing round tripping. So we can do the IPR, but I will be doing it clinically at every time I see them based on have they got tight contact points, which is based on my clinical judgment using the floss. And if you see here, the upper left central is rotated. We're going to need to do some IPR here because we know anterior teeth require extra space to align them. Okay. So that's a pretty picture. It's the staging which is important. So when we look at Bridget comes in, and Bridget's got a fair bit of crowding of the teeth, this is great because we've got crowded teeth, and all the principles that I've just told you about, we can go ahead and use the OPG. Now, this isn't perfect. We've still got a bit of a black triangle, but this was done with, I think, 30 aligners. It took us 7 months to treat them, 7.5 months, because we're now using aligners changing them on a weekly basis. Here we are, finished in 7 months. That's not bad for aligner therapy. You can start to see a little bit of that posterior open bite that we talk about. And we basically want to look at, when we plan a case, the more knowledge you have in orthodontics, the better, because we want to plan a case in very similar way to how we plan for braces. For example, in deep bite cases, when we do this with braces, we go ahead and we use like a reverse curve of Spee wire. And we overcorrect. That's what we plan. So we put this wire in which has this reverse curve. It's not to say that's the way it's going to end up. But if we don't overcorrect it, we won't get anywhere near it. And what we do in our fixed braces nowadays, we put bite turbos on to help open the bite. So the point that I'm trying to get at is, why should that be any different to what we do with aligner therapy? Because aligners are just a force system. So what we want to do with aligner therapy is actually overcorrect. We want to actually show the digital setup looking like this. That's not to say that's where it's going to end up, but that's where we want the setup to show us, so it ends up in the right position. This is the experience factor that we talk about. So we can go ahead and intrude the teeth, but we want to overcorrect it. And remember, whenever we intrude teeth with aligners, we need retentive attachments posteriorly. And they are horizontal attachments. Okay, we've gone through that before. So we have an intrusive force, but we're going to overcorrect. And in deep bite cases, we correct to at least a 2 millimeter anterior open bite. So when I do the setup, I want to see it like this, even another 2 millimeters of an anterior open bite. I will overcorrect it, always. And we remove the constraints. So in our fixed appliance therapy, we will go ahead and put bite turbos on, because the problem when you've got two pieces of plastic is you're going to get intrusion of the posterior teeth. And if you want to avoid that, which we do in deep bite cases, obviously, we're going to go ahead and put something like bite turbos on, and we do that in our aligners. And by doing that, we no longer have the posterior teeth occluding together. And that will save that intrusion that's been our bugbear for the last 15 years, the intrusion of the posterior teeth. So deep bite cases, you've got to think about, what do we do in fixed braces? Okay. So you still have to understand diagnosis and treatment planning and issues if you want to get the best results. So, for example, this lady comes in and we've got a pretty deep bite. Now, if we didn't do bite turbos, etc., we would never be able to open that bite properly. So once again, with all the principles that I've told you, we would have intruded the uppers, intruded the lowers at the same time. We would have retentive attachments on the posterior. We would have overcorrected. We would have put our virtual bite turbos on anteriorly, and we ended up with this result in about 9.5 months. And that's not a bad result with plastic. And then we need to understand that we have to overcorrect, because all the studies have shown that there is not a great deal of predictability with aligner movement, 30% predictability with extrusion. Distalization of molars is only predictable for up to 2 millimeters. And when we talk about transverse expansion, only 3/4 of what we program in do we get. We talk about premolar derotation, only 39% predictable. So they're not that predictable, so we have to go ahead and overcorrect. So we talked about deep bites. In deep bites, we overcorrect to give you at least a 2 millimeter anterior open bite. So that's what we would do in a deep bite setup. In an open bite setup, we actually provide a posterior open bite, and we overcorrect by giving that 3 or 4 millimeters of anterior open bite. So everything we do, we are going to overcorrect. We overcorrect with regards to expansion by about 2 millimeters per side, because we never get everything that we want to get. We overcorrect in our torque. So we overcorrect by 2 degrees for every 5 degrees of torque that's required. So we can figure out how much torque we've got, and we're going to overcorrect. So if we want 10 degrees of torque, we're actually going to put 14 degrees of torque into that setup. Okay. And then from a clinical point of view, to finish off, you guys have to make sure your aligners are fitting. So if they're not fitting, that's our problem. But if they are fitting, we know everything is proceeding very well. This was the case we showed you before. The lateral incisors are not extruding. Why? There was no attachment. So the first part of it is getting the right digital setup. That's the most important thing, getting the right plan. Making sure there are no constraints in the system, that's the most important part. But the clinical part for you is to have number 2, the good tracking, the perfect fit. And the key to this is check compliance, check the contact points. Very rarely there's a defect in the aligner. But if you check the contact points each time they come in, and you check it with floss, and there's no binding, then I can safely say to you, if you've got the right setup, that your cases are going to track perfectly well. Okay? This is what you need to do. This is what you need to instruct your patients to do at home. Check with floss. If there's any binding, get them to come in and just go in with a yellow IPR strip and reduce the binding. And if they're not fitting properly, go back and find the aligner that does fit and use the chewies to help seat it. If only one tooth is not fitting and you're getting very close to the end, consider resolving it in the refinement stage. Now just keep going and we'll resolve that one tooth in the refinement stage. And today, if you're doing everything right clinically, you've got the right setup, the best approach is just to do a case refinement at the very end. But these are the chewies, these are munchies, these work very well, they're a bit more expensive. If you're doing everything, we just use the chewies. If you're doing everything else and you're doing your IPR and you've got the right setup, this is all you need. Yeah, I love this case because this was one of my first cases where the patients wanted aligners and we were extruding the teeth and we didn't have it right. We didn't have the right attachments. The velocity was too great. Now we're going to be putting elastics on, rubber bands to try and recapture it. Okay, here's the patient wanting a really nice aesthetic system being Invisalign, and we've got all this stuff going because it's our only way to fix it. Had I known what I know today, that would never have happened. So on that note, we actually do have an aligner course coming up in November. So we've just given you the very, very little basics of what we've talked about, and we can talk about all of this stuff, how we do setups, etc., etc. We can do all that. So it's unfortunately going to be online now. It's going to be live streamed because of the COVID. Next year, we've got a 3-day course in Melbourne and Brisbane, and we've also got an advanced course if you're interested. And you've got an online recorded version. So if you want to know more about aligners, and I know Race is about to launch their aligner product, which from what I've heard sounds really exciting and probably the most cost-effective aligner system on the market. And it's about time that someone has come out with something more cost-effective than what we've had. So I congratulate Race, and I'm sure that'll be out in the very near future for you guys. But the principles don't change. Everything I've talked to you about, the attachments and the staging and everything else is really, really important. Down the track, if you're interested in having help with planning of treatment, because that's a big belief of mine, we actually have a special treatment planning service dedicated to aligners that we call CAPS. So I'm happy to talk to you about that. And my personal feeling is the more understanding of orthodontics, the more successful you're going to be with aligners. But if you've got the right people behind you, we can do a lot of the treatment planning for you, have the right technicians doing the setup, understanding it. You can get some great results, okay? But the more you understand orthodontics, the more aligner treatment is easier and more predictable. So on that note, we'll talk to you about the mini masters program later, but you guys are much more interested in aligners. But the other thing I want to say to you is RACE has organised to sponsor the Ortho Ed training program, and they have a deal where if you do our Ortho Ed training program, you can get, I think it's over $3,500 worth of RACE dollar credits. So speak to RACE, they can give you the detail. It's a great offer that RACE is doing, and they can give you all the information if you want to learn some more. Go through RACE, get your lab credits, etc., etc. So on that note, I'm also happy at any time just to do a no obligation, just call with you just to see what floats your boat, what are you interested in, and at the end of the day, I want to make sure that we can deliver on providing you with what you want, because life's too short. So I don't want to bring you into a course and it's not for you, and vice versa. So happy to spend 45 minutes and just talk about it. And if you're doing cases, happy to talk about those as well. I don't mind. So on that note, Matt, I'm just on time. I'm happy to take some questions. We've run through a lot of stuff very quickly, but it was hopefully a good overview on the essential things to look at for what I see as common mistakes that are made by dentists in aligner therapy. And hopefully we've addressed the 5 most common ones.
Yeah, look, Jeff, thank you very much for what is a comprehensive but simplified approach to aligners and straightening teeth. There's no doubt your knowledge is unsurpassed, and we thank you for taking the time to come here and share your knowledge with our team. The sheer abundance in numbers and registrations for this course shows the support you have and the knowledge that you bring to the table, and for that, I thank you. We have a bunch of questions here I was hoping I could run past you. David O'Malley asked an excellent question. Would you ever place lingual or palatal attachments?
That's a really good question. And yes, for example, when we do the bite turbos, we would actually have them in the setup and we wouldn't actually bod them on. So yeah, and yeah, I would put them on, but I do it very sparingly because it becomes really uncomfortable for the patient. So I try to avoid it, but it could be very useful sometimes with teeth that are in cross spot, and I want to add some different torque, so I can put different attachments on. So I think, David, your question is never say never and never say always. I would tell you, extraction cases, I might add buckle and I might add palatal attachments as well to get more control. I'd say it would only be in about 5% of my cases that I've ever done it. Okay, but yeah, it's definitely an option, but it's just very uncomfortable for the patient, especially when they take out your aligners to eat. So I try to avoid it as much as possible from that point of view.
Okay, and Nat Smith here has asked, what attachment type would you suggest for uprighting a measly tipped lower molar to implant placement? And is this a hard movement? Okay,
that's a really good question. As I explained, once again, let's talk about principles. We're going to use horizontal attachments for vertical movements and vertical attachments for horizontal movements. And what you're asking that is a horizontal movement. You need to do a tipping. So I would have the longest possible attachment on that molar to do so. Now, how easy is it to move that to? It depends. Is there a constraint with the second molar? Because if the second molar is there, yeah, that's going to be more difficult. I might need to upright the second molar as well as the first molar. And then we've got to look at what are the reciprocal forces. As I upright those, I'm going to cause some intrusion of the anterior segment. So I might need some retentive attachments. So you'd have to look at it case by case. But firstly, it would definitely be a vertical attachment. I think that'll go without saying. Could even be a sash attachment, where a 45-degree horizontal attachment to get both the extrusive effect that you might need here, as well as the tipping effect. So I'd have to look at it case by case, but be careful of the constraint with the second molar, because that's what's probably going to affect you as to the predictability of it.
Look, okay, we've got an abundance of questions here, but we're a little bit low on time, Jeff. So I apologise to everyone who sent all these questions through. It's a great opportunity to jump on board the OrthoEd Institute and sign up to get those questions answered in entirety. But there's one here, Jeff, I was hoping to ask, can we achieve the same result with aligners that can be achieved with braces?
Yeah, that's a really interesting question. My partner, Martin, my orthodontic business partner, Martin, he does about 400 cases a year with aligners, and his cases are brilliant. They really, you couldn't tell the difference between aligners and braces. And if you know what you're doing, yes, you can. The problem with aligners is they can be a little bit unforgiving. Yeah, if something doesn't go right, you've got to restart the case or whatever it be. But in principle, if you know what you're doing, there's very few cases that you can't do with aligner therapy. So to answer that to you in a short answer, I think the next 10 years, as things improve, aligners are going to be maybe 60% of orthodontics. I don't think some people say they're going to take over 100%. I don't believe they're going to, okay, because of cooperation, etc. But I think they're going to increase significantly. And with our knowledge, it's interesting. 5 years ago, I would have said aligners were terrible. And the last 5 years, the biomechanics and the knowledge that we've got has really picked up. And now it's a really, really good option for lots of patients.
Look, that's fantastic. And look, there is abundance of more questions. I do apologise for not getting to those due to time restraints. But look, race aligners will be coming shortly, so watch this space. Jeff's input has been integral into that product. So if anyone has further questions, feel free to contact customer support, who will talk you through how that's going and how that's tracking. Again, consider OrthoEd and get your information direct from the source. But again, I'd just like to thank you, Jeff, your knowledge and in simplifying what we thought was mythically difficult, and in no way do I mean too easy, but your education and your explanation no doubt will help our clinicians, and I'm looking forward to being a part of growing of this growing area. So again, thank you very much. I thank you to all of our people who have signed on. It's been enormous amounts of people across 9 countries. So again, I thank you for your time. I look forward to seeing you during the next Race Academy. And Jeff, is there anything you'd like to leave us on prior to departure?
All I would like to say, once again, thank you, Matt. Really look out for the race aligner system, because my discussion with Matt and Brad have been such that I really think they've nailed what the market really needs, which is a really good, cost-effective aligner system. And I think you might have it. You might have the solution to what everybody really wants. So I'm really looking forward to seeing it, go out to the market.
Yeah, thank you. And thanks to our business development director as well, Carly Makovich, who's not only put the academy together, but who's driving this with our data analysis and research and development team. So again, thank you, Jeff. And I thank you all for attending. We hope to see you soon at the next Race Academy live webinar series. Thank you all for your time.
Thank you.